Good afternoon, everyone, and thank you so much for joining us today. Whether you're a patient, a caregiver, a healthcare provider, or a friend of our community, we're so glad you're here as part of the Ottawa Pulmonary Hypertension Support Group special presentation. We do know how important it is to come together to share experiences, offer support, and stay informed about the latest in research, treatment, and care. So we are especially honored today to welcome a very special guest, Dr. Lisa Mielniczuk, who will be introduced by Ottawa's own lovely nurse, Carolyn, who is our dedicated, compassionate, and beloved PH nurse. So I will turn it over to you, Carolyn.
Thank you, Joanne. Well, it's my great pleasure to introduce Dr. Mielniczuk to you all today. Currently, Dr. Mielniczuk is professor of medicine at the Mayo Clinic in Rochester, Minnesota. And her areas of expertise, her clinical expertise, include heart failure and cardiomyopathy, right heart failure, pulmonary hypertension, management of transplant candidates and recipients, management of patients with left ventricular assist devices. And as most of you know on here today, Dr. Mielniczuk was previously the director of the Advanced Heart Failure Program and medical director of the Pulmonary Hypertension Program, which she co-founded in 2007 with Dr. George Chandy at the University of Ottawa Heart Institute. She's an active leader for the heart failure and pulmonary hypertension community. She is an active board member of PHA Canada's Board of Directors. She was previous board chair and currently vice chair. Also acted as chair of PHA Canada's Medical Advisory Committee. Dr. Mielniczuk's research interests include clinical outcomes related to heart failure and pulmonary hypertension, and the evaluation of myocardial energetics in right heart failure. She has a specific interest in evaluating metabolic adaptation in right heart failure and pulmonary hypertension, and it is my great privilege to have had the opportunity to work very closely with Dr. Mielniczuk. We all missed her greatly, but I'm sure these are wonderful experiences for her at the Mayo Clinic, and those patients are very lucky. Without further ado, please provide a warm welcome to Dr. Lisa Mielniczuk.
Carolyn, thank you for that very lovely introduction. I'm just going to start. So Carolyn and I have been texting a little bit back and forth about this, and she wanted to introduce me, and I gave her like a one line.
Yeah, saying, professor of medicine.
Yeah, and she said, "Is that it?" And I said, "That's all."
I know. I couldn't do that.
You pulled all that out from the internet somewhere.
That's right.
Very kind and totally unnecessary.
That's right.
But thank you for that.
Thank you for today.
Thanks so much for for coming out today and listening. I'm really happy to be here, and I love to I really do. Ottawa is in my heart. I spent my entire career in Ottawa, and I'm very new here to the system. So it's a welcome memory to come back and share things with our friends in Ottawa. So I'm gonna get started here. So there's so many things we can talk about, right? There's really so much change in the landscape of patients with pulmonary arterial hypertension, how we understand the disease, how we recognize the disease, and how we treat the disease. And, when I was thinking about what to do for this meeting today, I thought that this is a great time to really just talk a little bit about some of the very important changes in management, obviously, because people really are interested in what we're understanding about management and where we're going. And a couple of, I think, interesting things that reflect back on how we are diagnosing the disease. Now, I have some slides and sort of a relatively formal presentation, but by all means, this is informal. So, stop me at any time, but I do definitely would love to answer any questions you have at the end of it as well. So the first thing I kind of wanted to cover was our understanding of how we make a diagnosis of pulmonary hypertension. And I'm sure for everyone on the call, This is a life-changing moment when your physician says that they think that you have a diagnosis of pulmonary hypertension, and then you come to our clinics and we do all these tests and we do say that, yes, you have a diagnosis of pulmonary hypertension. And over time, our understanding of what that means has shifted. And a lot of what I'm saying is very recent and coming out of new guidelines that have just been published in the last couple of years. Ultimately, what I say to my patients is that pulmonary hypertension in and of itself is not really a diagnosis, but it's a classification of a whole bunch of different diseases that cause the blood pressure in the blood vessels that are connecting the heart to the lungs to be high. And that can be caused by a primary problem with the blood vessel itself. It can be caused from a heart problem. It can be caused from a lung problem or a whole bunch of other more rare causes. But ultimately, when we want to make the diagnosis, we use the measurement of that pressure elevation to make the diagnosis. And we used to think that that threshold to say someone has pH was a mean or average pressure in those blood vessels of 25. And in fact, in the last couple of years, we've done something really different. We've actually shifted the needle a bit. So we now say that someone might have pulmonary hypertension even if their mean pressures are only over 20. And why is that? Well, we learn as time goes on, we learn. And there's two important things we've learned. The first thing we've learned is that normal pressures are actually not 25. In fact, most people, whether you're sitting or lying, a man, a woman, wherever you live, however old you are, your average pressure is probably less than 15 if you don't have pulmonary hypertension. And so if you take 25 as a threshold, we may be missing some people who actually have the disease and we're not picking it up early enough. And this was some interesting work that showed or demonstrated how your risk of something bad happening, your risk of dying, for example, actually starts to increase when the pressures go above 20 and even above 15. So anything below this dotted line suggests you have an average risk of death. And anything above this line suggests that that risk is increased. And you can see that the higher the pressures are, the higher the risk is that something adverse or bad may happen. But that doesn't start at 25. And so if we say 25 is normal, we're missing all these people who potentially could be treated earlier. So I think that that's really exciting and allows us to get the treatments and the understanding of the disease into our patients earlier than we could have before. And the second thing that I want to talk about in the diagnosis of pulmonary hypertension is how we use the most common tool to make a diagnosis, and I'm sure you've all had many of them, and that's the echocardiogram, the ultrasound test of your heart, which is a wonderful test to screen for pulmonary hypertension, to estimate. Now, it doesn't measure. You need the heart catheterization to actually measure the pressures, but it can estimate the pressures are without having to put a needle in your arm or your neck or your leg. And it's very reliable. But unfortunately, not everybody has the right pictures or the right signals across the valves to get an accurate estimate of those pressures. And so we have looked at different ways to take different types of pictures with the heart to try to come up with an estimate of whether we think this person has pulmonary hypertension. And this is also very important because you can imagine if your doctor sent you for an echocardiogram or an ultrasound and they weren't able to pick up that signal to detect pulmonary hypertension, they might just say, you don't have pulmonary hypertension. And we want to move away from that now. We really want to look not just at that signal to estimate the pressures, but a whole lot of different things about the heart to help us to understand whether or not this patient may have pulmonary hypertension. And that could be the size of the right side of the heart, which is pumping blood into the lungs. It could be fluid in the heart. It could be different valve abnormalities, all of which might suggest that this patient needs to be thought of carefully. And then the last thing I'm going to say about understanding a diagnosis of pulmonary hypertension is this algorithm of how we approach new patients who come into our clinic. And the details are maybe not that relevant, but there's two things that I think are relevant. The first is that very simply, with simple non-invasive tests like lung function tests and ultrasounds of the heart and ECGs, we can probably have a good sense of whether this person has significant pulmonary hypertension about 70 or 80% of the time, even before we do a right heart cath. And many of you may not even need a right heart cath. However, there are a few of us who have certain ways that they present their feeling, or certain things we see on that non-invasive testing where we really do believe that this person has a diagnosis of pulmonary arterial hypertension, that disease that's caused primarily by abnormalities in the blood vessels of the lungs, which we're going to focus on for treatment. And in those patients, it's really recommended that your family physician or your internal medicine specialist or your cardiologist or your respirologist, who's ever looking after you, is fast tracking you to a PH clinic. And Carolyn and Dr. Chandy and Dr. Contreras and Dr. Stewart and all my colleagues back in Ottawa, we review our requests for referrals every day. And we read through all these tests every day, and we try to triage our patients so that we can make sure that patients who need to see us quickly get in to see us quickly. And I can't say, I've worked with Carolyn for many, many, many years, and no one does this better than she does. It's a really important step in the pathway to diagnosis. So let's shift a little bit and talk about treatment, because I think that that's really very exciting. And for those of you that have heard me talk on treatment, or some of my colleagues across the country talk on treatment, you know that in Canada, there are many different ways we can treat this disease. There are 10 or 11 therapies that we can use, and we use them in different combinations and different strategies depending on the particular patient. It is not a one-size-fits-all program. Every treatment decision we make is individualized to what we think would be best for that patient. And it is very much what we call shared decision making. We have recommendations about what regimen we think is right, but it's really important that you, as patients and caregivers, feel empowered too, that you understand where that rationale comes from, and that you feel comfortable with the suggestions that are being recommended, right? Because not every shoe fits every foot. But ultimately, in 2022, we had 3 pathways of treatments. We had pathways of treatments that help to reduce the harmful effect of a protein called endothelin. And those are medications called macitentan, ambrisentan, bosentan. Those are tried and true therapies, oral pill therapies that have been around for a long time, and they're very, very good. And then we have medications that help to really dilate the blood vessels of the lungs and reduce thickening of the lung vessels to a certain extent. And those are things like sildenafil, Adcirca, Riociguat, other medications that you may have heard about. And then we have this third pathway of medications that work on something called the prostacyclin pathway. And prostacyclins are there, again, to help to open up those blood vessels that are so thickened with high pressures. And these medications could be pill forms, things like Selexipag, or they could be subcutaneous medications, or they could even be intravenous medications. And so we have very good recommendations in 2022 about how we should use these medications and in what strategy. But I think what is really fun is that even just in the last 2 years, there has been tremendous advancement about new pathways that might be targeted to have even more effect on patients with pulmonary arterial hypertension. And the pathway that I think is on everybody's lips, of course, is this pathway right here, the activin signaling inhibitor, the medication called sotatercept. And so I'm going to spend quite a bit of time talking about sotatercept. But I want to tell you that sotatercept, although it's a fantastic drug and I'm very excited it's on the scene, it's not the only pathway of promise. There's other pathways of promise we'll talk a little bit about called tyrosine kinase inhibitors. And then over here, you see a whole bunch of other different pathways that are being explored either in animal models or early clinical models, or even just, smart people thinking, hey, this might actually have some benefit for our patients too. So let's talk about sotatercept. You've probably heard conversations about sotatercept. I know PHA Canada has been fantastic in moving the needle forward with trying to get therapy for these patients. Now, sotatercept is a tricky drug. Tricky only in the sense is it may be a little bit to understand how this medication works. So one of the important things to remember that, as I said, pulmonary hypertension is a condition where the blood pressure is high in these blood vessels. And one of the most important reasons that the blood pressure is high is because the blood vessels vasoconstrict, right? They get really, really tight. And so the pressure inside the vessel increases. But just as important, if not more important, the vessel wall itself also becomes thickened. It becomes abnormal, and there's abnormal cell growth inside those blood vessels. And in patients who have pulmonary arterial hypertension, there's an imbalance between the safety mechanisms in our body that help to reduce that abnormal growth and help to prevent a proliferation. So to prevent the abnormal growth and to reduce the abnormal growth when we see it. And that imbalance gets out of whack when you have pulmonary hypertension, and that's what causes the thickening inside the blood vessels. So what sotatercept does is it helps to restore that balance between growing too many cells in the blood vessels and not growing enough cells. And it does that largely by this molecule called activin. It traps. So you can think of sotatercept as these little blue circles that trap these molecules called activin, because activin is responsible for some downstream signaling pathways that cause our cells to start replicating over and over and over again, particularly in the pulmonary vasculature. And sotatercept also helps to reduce the blocking on antiproliferation, so that it awakens the proteins that are going to try to reduce proliferation, and it's going to put the proteins to sleep that are working on growing proliferation as well. And as you know, there was a really important study 2 years ago called Stellar. It was the first time that this drug called sotatercept was being used. And it was what we call a phase 3 study, an early study, but it involved 300 patients. Many of them were female, as we often see in patients with pulmonary arterial hypertension. And interestingly, these patients had PAH for a long time. In fact, the average duration of patients living with the disease was 7 years. So these were not new patients. These were our patients, some of us who walk around day to day living with pulmonary arterial hypertension, where you think maybe the medicines I'm on are good enough. And those were the patients that went into the clinical trial. And you can see that 40% of them were already on intravenous therapy for pulmonary hypertension, and 61% were already on 3 medications. And so you might be thinking, I'm already on 3 medications. Is there really a benefit in adding a 4th medication? And so what Stellar showed is that actually there probably is. Now, it was a smaller study, and the primary endpoint means the most important objective that the trial had to demonstrate success to be a win, a positive trial. And what their most important objective was, they wanted to show that patients who got sotatercept were going to walk more. And did they walk more? They sure did. They walked 40 meters more. And for all of you who've done 6-minute walk tests, you probably will agree with me that 40 minutes is a good walk. Not only did they walk 40 meters more, but even many weeks after they started taking the medication, you can see in that yellow line that improvement was sustained. And for people who were not given sotatercept, there was really no improvement in how long they walked over time. There was less admissions to hospital, and patients felt better. Now, there were some downsides to sotatercept, and because of the way it tries to restore this imbalance between proliferation and anti-proliferation, one of the downsides is it can affect the blood vessels that cause bleeding. And so sure enough, people who got sotatercept had more bleeding, and we could talk about that as well. They had more lower platelets, and they had more bleeding effects, either bleeding in their tummy or other bleeding in their nose or other places. But we also saw that sotatercept helped the pressures to go down. So people walked more, but they walked more because the drug did what it was supposed to do. It lowered the pressures in the lungs, and it lowered the stress hormones in the heart, your BNP. And I'm sure you've heard Carolyn talk about that. This is a complicated slide, but what what it is showing is that all the people who were on placebo are the blue dots, and all the people who got sotatercept were the crosses, the red crosses. And you can see, if you look at the relationship between how well your pressure reduced and how well your stress hormone BNP reduced, all the people who had the most favorable reductions were down here, the people who got the drugs, right? And the people who got placebo didn't have that same effect. We also saw that sotatercept improved many things about right heart function. It improved the way we measure right heart function, and it improved the way the pressures are seen in right heart function. Now, why is that important? We think that's important because one of the most important ways we understand the disease and how well people are going to do, or how concerned we need to be about them, is how well the right side of the heart can accommodate or manage that extra pressure that it has to work against from pulmonary hypertension. And if the right side of your heart can accommodate that pressure well, then there's less chances that you're going to run into trouble with the disease. And so sotatercept not only lowered the pressures in the lungs, but it also helped the right side of the heart to work better. And so because this was such an exciting thing, about 6 or 7 months ago, when the World Symposium of Pulmonary Hypertension took place, they updated the treatment algorithm, the way we sort of understand how to approach all these medications. And they added in activin signaling inhibitors, or sotatercept, almost at every stage of disease. Not when you're first diagnosed. We don't know that yet, but that might be coming. But once you've been on treatment, you need to be followed very closely, every 3 to 4 or 6 months. And the goal is for our patients to be low risk. That means to have markers in their assessment that suggest that they're going to do well in the next year. And if they're not low risk, we should be adding on treatments like sotatercept. And in almost any risk category, sotatercept is a good drug. All right. So that's where we were 6 months ago. Now, I'm sure that for those of you that follow this, the news and follow the treatments for pulmonary hypertension, you already know this, that less than a month ago, another big study was published on sotatercept. And this is really exciting. And this just came out. This is literally hot off the press. It's probably 3 weeks old or less. And this was the results of the Zenith study. Now, Zenith is another sotatercept study, but this time Zenith did something different. They took our patients with pulmonary hypertension who are at a higher risk, so patients who are sicker or have more advanced disease, and they wanted to ask the question, would sotatercept help patients who have more advanced disease? And they identified patients who were sicker by something called functional class, which is really measured of how short a breath you are with your activities, and something called a reveal score, which looks at your shortness of breath, your stress hormone, the NT-proBNP, and some other things. And they selected out those patients who were at higher risk. And they took 172 patients and they randomized them again to sotatercept or placebo. Now, patients were a little bit older than the other study, but the same percentage of females. And because they were sicker, not surprisingly, more of these patients were on more therapy. So now we're seeing 72% of these patients were on triple therapy, and 59% were on IV therapy. The other thing about Zenith is so we talked about primary endpoint, right? That is the main goal for the trial. That's the bar that the trial has to pass to say it's a positive trial. Now, the bar for Stellar was 6-minute walk test, which means it was how much further you could walk if you were on the medication. The bar for Zenith was different. The bar for Zenith was what we call a composite endpoint, which means it looked at 3 things. It looked at death, it looked at your need for lung transplant, or it looked at whether or not you went into hospital because your pulmonary hypertension got worse. And it looked at the time to any one of those events. So that's a really high bar for a medication with pulmonary hypertension. And they were not going to say the drug was positive unless there was less of those events in the patients who got sotatercept compared to placebo. And as you might know, this trial was actually stopped early. There are these things called safety boards, and they review the results of a trial as the trial is progressing. Because trials, clinical trials, are looking at medications that we don't use in day-to-day practice. So they have to monitor signals that suggest either the drug is not good at all, i.e., it's causing risk or harm to our study patients, or the drug is so good that it seems not fair to continue the trial because the people in the placebo arm aren't getting the benefits of the drug. And what happened was the trial was stopped early because the signals suggested that the drug was so good that it didn't seem fair to continue to put people in this trial because they would have a 50% chance of getting placebo. And so they stopped the study. And when they stopped the study, they saw, and this is that primary composite endpoint, right? So this is the incidence or the risk of developing one of those three things. And the orange line are the people who got sotatercept. And you can see, right, nobody has the event when the trial starts, but if you go out to 120 weeks, so that's, a few years, you can see that people in sotatercept were less likely to have one of those events. And people on placebo, now they weren't just on placebo, remember, 70% of these people were on 3 medications already for their pulmonary hypertension. People on placebo, you can see over time, were more likely to have one of those 3 endpoints happen. And this was what we call a 76% reduction. So can you imagine that? How exciting is this that we now have a medication that can reduce the risk of one of these really bad things happening to our patients by 76%? If you look at just survival alone, you can see that there's a suggestion that patients who got sotatercept lived longer than patients who got placebo, but the difference between these two curves is what we call not statistically significant, but it's close. Now, sotatercept also had other important things happen in the Zenith trial. People felt better, their quality of life improved. Their risk score went down, their pressures went down, all kinds of good things. And then there was one other thing. Oh, and they walked more too. They walked 45 meters more. There's one other thing that sotatercept showed, which we haven't actually seen in other clinical trials of pulmonary hypertension medications. And that's that people who got sotatercept had less chance of needing a lung transplant than people who did not. And this was statistically significant. So very exciting data. Now, no medication is perfect. You guys know that better than anyone. There were more side effects in the sotatercept arm. People had more nose bleeding, they had more gum bleeding, they had more back pain and vomiting. Those are not small side effects, right? And so we have to manage those medications. But in fact, if you look at the two arms, the placebo arm, so the arm that didn't get the active therapy, and then you look at the sotatercept arm, it was actually the patients in the placebo arm that were more likely to stop taking the medication. So I think that that's important to know. So this is super exciting, and I'm sure if there are questions, I'd be happy to chat with you about them. And then just in the last couple of minutes, I want to, just talk about another therapy that I think is going to be very interesting, and that's called seralutinib. And seralutinib is also like sotatercept in that it's trying to restore some of that imbalance between proliferation and inflammation inside our lung vessels, which is causing some of this pulmonary hypertension problem that we're seeing. And in animal models, this is an inhaled medication, so like a puffer or inhaler. It showed really important benefits in helping to reduce pulmonary hypertension. But what about in patients? In patients, there was a small study called TORREY just published last year, where in a very small study, 86 patients, they were randomized to get the inhaled seralutinib or to continue on their pulmonary hypertension medicines. And it's a small study, so, it doesn't have the big bells and whistles of what we just talked about, but certainly what they saw was that there was a good reduction in pressures, and patients did walk a little bit more. But what's, I think, coming and really exciting is that there's a possibility that one of the ways this drug may work is it may help to grow new blood vessels inside the lungs. And you can imagine if you have more blood vessels in the lungs, then the effect of the high pressure is going to be reduced. And this is just an illustrative example. This is a patient who was on placebo, and this was a patient who was on seralutinib. And you can see from baseline to being on the medicine for 24 weeks, if you were on placebo, you don't really see a lot of growth of new blood vessels, right? It looks pretty similar. But if you look at the patient who got seralutinib and you just look here in the right upper lobe, you see, there's lots of blood vessels, but then look what happens after 24 weeks. See a lot more blood vessels. So this is very exciting, and this is being looked at in more studies as we go further. And so I think, if we look at treatment, all the medicines that you guys are on for pulmonary arterial hypertension are fantastic. There's lots of them, but they're really focusing predominantly on vasoconstriction, on taking that blood vessel that's really, really tight and helping to open it up a bit. And we have new medications now, so sotatercept, which is ready for go, and seralutinib, which is not quite ready for go, which may work on some other brand new pathways, which are really, really important. And it may be that we get to a time where we can use these medications really, really carefully to keep our patients in that low status, because that's the status that we know and we can feel good that they're going to do well for a long time. But it may also be at some point, and colleagues like my friend Dr. Weatherald are looking at this, that maybe that once you get to a low risk status, maybe there's a time where you don't need to be on 4 medications anymore, right? Maybe it's not just about how many medications you're on, but which medications you're on. And maybe it's possible that if you do really, really well on sotatercept, there might be a time where you could come off your prostacyclin, right? Or you could come off one of the other medicines. And we certainly don't advocate doing that right now, but this is where we want to go in pulmonary hypertension. And I think that in the next few years, we're going to see some more answers there. So I'm going to stop there. That's really what I wanted to chat with you about.